I guess this is the first presentation here for the CGR. No is right, but partly no. The title is Fighting Blue. This is basically how to fight with depression. This is one name which is on the Google for many organizations, many manuals. We have taken that and partly abbreviated. First, let me start with the relevance of this topic, as we mostly start here. As everyone occasionally feels sad, but the feelings are usually short-lived and pass within a couple of days or minutes or hours. When it is persistent, it interferes with daily life. It causes a lot of distress to the person and the surrounding ones. It's very common, but serious illness many times. Many people with depression who never ask for the treatment, but it has been seen the people who even have severe depression, they improve mostly with the treatment. Currently on the globe, nearly 350 million people are depressed, and one of the international multicentric study, it was found nearly 1 in 20 was found to have depressive episode in last 1 year, and reported lifetime prevalence is up to 20%. And typically it starts in young age, and it has a lot of impairment, dysfunction, disability, workload because of the recurrent depressive disorders, which is a norm in most of the cases we'll discuss. It has been quoted second most common cause of disability adjusted life years after the low respiratory tract involvement. And it further causes major burden for the suicide and different type of ischemic heart diseases. This highlights us to talk about this, make us as a priority disorders to treat and manage and importantly prevent. There are so many things here to discuss today. My talk here will focus on some of the cases, their management issues, what do we learn. Those different strategies, especially psychosocial or counseling strategies, are useful for everyone, for me, for others, even who are not having the depressive episode, but just how to prevent this. So we'll talk about the prevention as well in the last, and not going to give you this detailed guideline of this depression management, because this is not the case here today. See, how does it present? Deepika has later quoted on the media that she has depression in 2014 while shooting for Happy New Year. She has taken medicine, counseling, she improved. Her main motive to put this on the social medias and different type of the medias just to create awareness, and later she has even followed that to create one NGO for different type of the awareness, especially mental health. We'll talk about that. In the scientific literature, the typical symptoms are found in depression. The most common: sadness or depressed mood, loss of interest and enjoyment in previously pleasurable activities, reduced energy which is leading to fatigability and decreased activity. Other symptoms are reported: decreased concentration, decreased self-esteem, guilt, pessimistic view, many times ideas of self-harm or suicide attempts, or sometimes completed suicide, disturbed sleep and appetite. Many of the patients presenting to us have one or other type of the physical symptoms which is quoted as a somatic symptoms in form of decreased weight, marked loss of the libido, early morning awakening, psychomotor retardation, morning worsening. Depend on these criteria, we usually make the depression diagnosis, which is mostly in our case it's clinical diagnosis. We have different type of the instruments, psychological assessment, which we use in sometimes when we need. But in many cases don't stop here. They go to this end which we discuss. Partly we will discuss this issue as well, not in detail. It always comes with n number of complications. As we told that this is the second most common cause of disability worldwide. It creates a lot of interpersonal problems, different type of the medical comorbidity, cognitive impairments, risk of suicide, increased mortality, diminished health span or life span. It's in international literature, nearly 10 years are lost, or people have premature death because of depression and associated disturbances. I'm going through three case details which were presented to AIIMS Jodhpur in a sequential difficulty mode, that because first case was easy to manage, second was difficult, third is most difficult. With some lessons for the confidentiality, names are removed here. This is Miss X, 19-year-old 10th pass single female student from Jodhpur. She has first presented to us on 9th of June this year with a 3-year history of sadness, decreased pleasure, weakness, suicidal ideas, past history of deliberate self-harm in form of consuming 4-5 sedative pills. Details are not available, which was into 2 years back. Though she is denied fresh stressors, no past or family history of psychiatric disturbances. Here she was diagnosed dissociative disorder, moderate severity with intentional self-harm by sedatives in past. Detailed investigation found iron deficiency anemia. For that she was managed. She was given from our side escitalopram 10 mg with clonazepam SOS for managing her anxiety and sleep disorders or sleep problems. Family was psychoeducated about the illness, medications, risk management. No harm contact was made with the patient, and detailed explanation for how to manage the risk to the family was told. Different type of relaxation was taught in this patient. Here the outcome, she started improving within a week, and within a 1 month she completely improved without much effort from our side. This is typically we are managing, but and second good thing, this was the first visit to the AIIMS. She has not visited any other psychiatrist before this, and she has presented here first episode of depression. That's why many times easy to manage. The next is Mrs. Y, 34-year graduate, married female from Jodhpur. She has first presented to our OP 24th of July last year with a history of 4 years episodic depression. That time she has had second episode of the depression with a duration of nearly 8 to 9 months with a similar complaints as I reported in earlier patient. No family history. Here stressor was mentioned, unlike the other earlier case. Here the change of the house, earlier she was in an extended family. Thereafter they bought their own house, shifted to the nuclear family in a distant place. There was nearly 3 deaths in her family in last 1 year, so that was the main precipitant to have this depression, that too more resistant here. She was diagnosed recurrent depressive disorder with moderate severity. Investigations were within normal limit, routine investigation. She was tried on first escitalopram, started 5 mg, increased to 10, then to 20, no much respite, then dosulapin 75 to 225. Sorry for this, no benefit was there. And currently she is on venlafaxine, gradually hiked to up to 225 mg per day, on which she is well now. Sedatives are prescribed off and on now. She was taught different type of relaxation exercise, physical activities. Though this case was not improving initial nearly 8 to 9 months, different type of fluctuating symptoms, and sadness was almost there, except sometimes 10, 20, 30% improvement. That's why this case has gone for detailed psychotherapy, which we call counseling in general terms, and here we have used cognitive behavior therapy. I'll detail in the later section what is this for just understanding for the house. Here in the outcome, so far she has been followed up 18 times. Improvement was fluctuating initial 8-9 months. Now she is nearly 95% fine with the patient in the family course for last 10 months. She is regular on the medication, general advices, and follow-up. The third case shows here, this is the Miss J, Jed, 30-year diploma holder who is single from Jodhpur. She has presented to our OPD on 4th of February this year with a history of nearly 11 years of depression, which is typically episodic. Mother reports 2 to 3 episodes in a year. Every episode is for nearly 2 months. In between she is well for nearly 2 to 3 months, though the in-between improvement part is with complete remission. The background stressor reported, possibly mother has had psychosis, parental discord was reported, and subsequently father has gone for second marriage. And history of maltreatment from the stepmother, which were the main stressor in the background. Now she is presenting to us nearly 15 days history of the slow moods, decreased pleasure, decreased interaction, weakness, disturbed sleep and appetite, occasional death wish, but no suicidal ideas or plans. This case makes us more difficult because she has seen almost every psychiatrist in the Jodhpur except AIIMS Jodhpur before coming to AIIMS, mainly because of the chronicity, resistance, and she was not improving rather than the shopping. She was diagnosed recurrent depressive disorder, moderate severity, investigated, found vitamin D deficiency, treated for that. From our side, initially started on escitalopram 10 milligram, increased to 20 gradually as she was not improving much. Again, the fluctuations continued. That's why later added to agomelatine, which is a recent arrival nearly a year before in India. And for sleep, zolpidem was given, which she's taking off and on whenever needed, not on a regular basis. Here, the family sessions were taken in detail. Yoga, brisk walk, functionality was taught to her, how to increase her functionality. Since this case was most difficult out of these three cases, anyone in our OPD, someone who is presenting with a depression, main because of the chronicity, psychosocial stressor, and here she was started initially on cognitive behavior therapy, but later moved to mindfulness-based cognitive therapy, which we'll discuss in the later section. What is this? So far, 14 follow-ups have been done. Status currently better for last 10 days, unlike the earlier case who is better for last 10 months. Overall, fluctuating improvement, no much respite for the longer time. So that's why it's a good challenge for us to take her mainly for the psychotherapy counseling. So here we'll connect these cases in the later discussion. First start, why do we have depression? There are so many causes, so many problems, from the faulty wiring, genetics, immediate stressors, cognitive distortions, many times the thought problem, and most of the time, or in some cases, we found environmental problem. As in the case 2 and case 3, we found some social changes led to depression or increased the vulnerability. If we see the typical hypothesis, the normal state, we have a good amount of monoamines, especially serotonin in the synaptic left, but when one is depressed, monoamines, especially serotonin, is down. So most of drugs are behind this hypothesis. Things doesn't stop here. Other than the serotonin, we have norepinephrine, dopamine, glutamate. At the receptor level and the postsynaptic level, molecular level, there are so many theories, and now drug developments are going towards these. It's good to have the understanding because now drug market is moving better. Neurotropic mechanisms are also taught in this disorder. Normally we have this presentation, and when one is depressed, then the neurotropics are pretty less, growth is pretty less on the synapses and the different neuron structure, but once one is treated, again normal. And as I said, the drug development is behind these. Mostly we are using different type of the reuptake inhibitors, monoamine reuptake inhibitors. The green one, SSRI, is specific or selective serotonin reuptake inhibitor, which takes mainly the serotonin on the action. Second most common is use SNRI, where serotonin as well as norepinephrine reuptake inhibitors are there. The down in the line is vilazodone, which is a recent arrival in India nearly a week back, which is working on specific serotonin reuptake inhibitor as well as 5-HT1A antagonist, which are the presynaptors. And the different other chain of antidepressants also with us in managing case-to-case side effect and resistance potential. Then we go to different choices. But still most common over the world is SSRI. Different drugs are in the pipeline managing to work on different monoamine strategies, and also on glutamate, cyclic AMP, PD inhibitors, glucocorticoids, central peptidergic systems, galanin, and different drugs are in the pipeline to work on intracellular component, especially cyclic AMP response, binding protein, and BCL2 stimulation. Just this to give us more hope, because the drug market is moving like anything because of the better understanding of the neurobiology. So not merely a psychological disorder, it has a good neurobiological understanding. This to see our management, especially antidepressant. Usually persons who improve with the depression, here we continue their antidepressant in the continuation therapy, because many times they have risk for relapse. Some of the cases who have recurrent depressive disorder, there we go for maintenance therapy. We'll talk about the issues here. Recurrence risk is very high. We'll come in the next slide how much. The different risk factors is the more prior episodes, incomplete recovery from the prior episodes, severe episodes, chronic episodes, and bipolarity or psychotic symptoms are there, means delusion, hallucination, or oddities with the depression. So more chances of recurrence. In addition, if psychosocial stressors persist, environmental stressors persist, yes, good risk. After the first episode of this depression, the nearly 50% risk to have a second episode in future. One has 2 episodes in past, Risk increases up to 90% if 3 or more episodes, then more than 90% risk to have again depression in future. This makes case for psychotherapy because nobody wants to take medicines for long, and even patients who are taking, they also have a lot of fluctuation in next episodes because of vulnerability to the mind, because of negative thinking many times associated with depression, because of dysfunctional aptitude, and more so mind is vulnerable. Even the next second, third, fourth episode comes without stressor, typically because of the kindling phenomena taught here. So we'll be having some discussion on what is cognitive behavioral therapy, what is mindfulness-based cognitive therapy. Let me clarify here, this is not for the details, but yes, these principles will be useful for each of us, because I am following some of this just to keep me up. Not exactly for the depression, but yes, how to stay happy. Cognitive behavioral therapy basically deals with the one type of the psychotherapy or counseling techniques where we are dealing for the cognition or thoughts or explanation as well as the behavior, how to change. Why? Shown with this model, because these three things, mood or feelings, thought or cognition, behavior or actions are all interlinked. One is low in terms of the feeling, having negative thoughts, and that's not having any interest to do anything. So here we touch the action or behavior part, improve the functionality, it's one or other schedule, thoughts improving, subsequently feelings are also improving with the counseling technique, rather than once we are on the bed throughout the day, more and more depressed. Here in the classical, in the depression, person feels negative about the self, negative about the future, and as negative about the world. We classically try to break the cycle here in this therapy. This is with a background of the case 3. It's a general model of the cognitive behavior therapy. Many times one is having difficult early experiences which is later formulating one or other dysfunctional assumptions. One or other incident happens in initial episodes. Subsequently those assumptions are activated, negative automatic thoughts are seen, subsequently depression. As a case 3 I just told, in the background stressor, mother possibly has that psychosis, father-mother has discord, later father is married to other woman, stepmother was not treating her well, she was sent to mother's house or the grandmother's house where she was not taken care properly, and then these assumptions are with her. That's why she is the most difficult case, 11-year history, frequent episodes, nearly 2-3 episodes in a year. Whenever some or other thing happens, critical, minor or major, she has having depression. So here this cognitive therapy explains us what is the model. There are different type of the triggers, subsequently behavior is disturbed and person is more so depressed. We need to break this cycle with the cognitive model, and same day in day out happen, one or other things happen, we feel bad, and then it takes some time long, sometime easy, minutes or seconds, depends on our approach. This therapy teaches because many times we have negative thoughts which are driving our emotions, and then subsequently we are more depressed or down. So to come to the last here, the person is having some problem with the work, with this assumption that I have messed up everything, feeling low. We teach them what may be the rational thinking. There may be different thinking. You might have not finished, there was some other pressure, or maybe work was not okay, maybe you could not understand the things. Otherwise you are doing well in different areas of the life except that project, so you can do. Subsequently the anxiety or sadness has reduced here to half or more than half after the rational thinking. But many times we don't have rational thinking, that spiral goes on, typically in depression. So then what is mindfulness cognitive therapy? It's easy to understand. If we had mindfulness in cognitive behavior therapy, that has become mindfulness-based cognitive therapy. Slightly difficult if most of we don't know what is mindfulness. So go through slightly what is mindfulness. It's not something related to IQ or intelligence. It's hardly anything related to that here in this concept. This is basically an old Indian or ancient Indian concept which is later taken up by the Buddhism and made the integral component of religion. They are practicing on a daily basis. This is the one technique added in all type of counseling techniques or psychotherapies, which are the newer ones, because this is very useful in depression, in personality problem, in aggression, in drug abuse. Everywhere now the mindfulness is a one component. Then what is this? Is it mindful of so many things, or is something else? Some contemplation. We commonly see whenever we are working, we think to sleep. Whenever we are going to sleep, then we think about work. Mind has a lot of clutter most of time. We usually not in present, sometimes thinking about the past, sometimes future. So here is the definition of mindfulness by the Kabat-Zinn, the renowned philosopher. Basically, it's meaning paying attention in a particular way. How? First, focusing on the purpose, staying in the present, going non-judgmental for some time till you are interacting with the situation to manage your responses and better observation. Once work is done, meeting is done, day is going to be off, think about past, think about future, think about different judgments, what has happened in that meeting and the interaction, what is the benefit. Overall, we are more focused to the action, paying more attention to the present, inputs are better, judgments are less, reactions are less. Overall output is better. Why? Generally we have reactions, but when we follow some mindfulness or one or other contemplation strategies, become responses, and definitely responses are better for most of us day-to-day life. It increases our awareness, it increases our acceptance, it increases our present-based approach, because many times 30-40% of my attention in the past, 30-40% in the future, 20% here. Inputs are less, output is less. Let me improve my input, output will definitely improve. So it improves cognitive emotional flexibility, it improves our non-judging awareness. Subsequently, we have better physical well-being, better psychological well-being, and undoubtedly results. Now moving from the patients to the counseling technique to the general strategies how to help others with their depression, because this was my main motive to talk here. Since this is a scientific forum, so we started from the patient and the management, but yes, we should know the general principles. First, to helping yourself. If one is, then better to talk to somebody whom you have better trusting relationship. It lightens the burden, it works out the practical solution, because many times when we are stressed, solutions don't come in a better way. Try to keep as active as possible, because normally maladaptive behavior says us, stop, no work, be on the bed, don't talk to anybody. It increases the depression. Avoid overstressing yourself, learn problem solving skills. We'll talk in brief what is this. Remember, you are not alone. Depression is a common problem, can be overcome. For the parents and the teachers, if the student or child is having depression, then better to ask sympathetically how are they feeling, helping the child. Different type of the consultation to physician or to mental health professional depends on the need and the availability. Support is the must. Listening, avoid undue criticism. The most important, remain connected, because many times it's the key to success. Become informed what is happening, what is not happening. Restrict access to different type of the objects which have potential to harm, because suicidality comes many times in the depression. One has to be empathetic, understanding. Don't try to over-cheer the person or cheer up, because depressed person will stop talking or stop sharing. Avoid critical shaming statement, challenge expression of hopelessness, because we have to break that thought phenomena that nothing can be done. No, everything can be done. Let us take some help, let us sit, let us discuss. Emphasize that this is a treatable disorder. That's the beauty of this disorder. Most of the cases improves completely 100%. So this is a passing phase of some shadow. Emphasize on this, then seek consultation. Encourage them to seek consultation. The key is liaison with the psychiatrist, counselor or support system, because this is the key. Most of cases we succeed. Coming to how to reduce this disability, as I initially said, this is the second most common cause of disability worldwide as per the Disability Adjusted Life Index or Disability Adjusted Life Years studies in 2010 and 13. It was quoted to be second most common cause. Can it be prevented? Because of this, we have a lot of concepts: psychological well-being, positive psychology, which is a science which teaches us how to keep ourselves up happy. We have to talk something about the mental health. This is the one definition most comprehensive by WHO, where individual realizes his inner abilities, can cope normal in the day-to-day stresses, importantly more productive, fruitful and contributing to his or her community well. This concept is rising. The studies have found that we can prevent nearly 25% to 50% depression in the selective group. Universal prevention has not been tried in the studies, but yes, we have general strategies. I'll take 5 minutes more, sir. Thank you. Good to be assertive, because many times this is a cause, either we are passive or aggressive, both disturbs ourselves as well as to the system. Whenever some problem talks about that, we need to learn good problem solving skills, which is a one concept, beautiful concept, very few people are having, but who are having, they are very successful in the given fields. Here, how to identify the problem, go for the different information and creating ideas, and then out of different strategies, select one better strategies and build upon that in action mode. Once you are done, then evaluate. It teaches us not to be impulsive in doing anything. Just think about different strategies. Positive attitude is key. Here we say that everything has some benefit. If we go with that, then a lot of learning, better approach. Most of the strategies are discussed on another forum, but just as a quick recap, positive thinking is key. If I am positive, then I am happy. This we have discussed in one forum, how to have better problem solving based approach or coping rather than emotional coping, which many times we have. Problem solving coping says here to take it as a problem and to go for the solution. Don't just to manage the emotions, because once the problem is solved, you are happy. So let us have better problem focused coping. We need to have hobbies. If not having time, then need to have some time. Need to have some friends with whom we can connect, we can hang upon, and we can share better. This is the most important concept in the strategies. Happiness. Many times I talk to myself, and many times in my classes I talk to students, how happy are you? Just rate nowadays. Then scientists, psychologists have derived happiness formula. It is said that it has some vulnerability with the biological, some are related to the circumstances, but we use voluntary actions. What are we doing? Any guess how much contribution is of the voluntary action? Nearly half contribution. Circumstances contribute hardly 10%. Depends on the people, depends on the approaches. Which is most important, because the highest level of success is how happy are we. Exercises, undoubtedly it helps. We see people who are exercising, they are more or less more happy than the other population. Mindfulness, we have had a talk. Daily reflection is very important, not to collect any clutter in the mind, better to improve. There's a good amount of scientific studies which are talking on spirituality and religiosity, helping in different types of the physical disorders and psychological disorders and general well-being. In that line, meditation, yoga is discussed in detail, and now a good amount of scientific studies, randomized controlled trials. So not just I'm doing that, so I'm talking. No, science is saying. One thing I missed in the general strategy. Anybody can have some guess? To keep us up, yes, this is the most important concept, scientifically proven, because now a lot of studies are there, different type of the nutritional deficiencies, especially B12 with folate, different cofactors, vitamin D. If low, we have more mood swings, more fluctuations, and many times depression is difficult to treat even with antidepressants if these cofactors and vitamins are less. So undoubtedly good role of nutrition, good role of staying relaxed, and if nothing works, go for serenity prayers, or even on a daily basis it helps to keep us up and keep something on the God. Why to take all these stress on our head, or Almighty, whatever we follow. Things don't stop here. Why? Because we have so much stigma. People hardly come, hardly talk, hardly discuss. It's easy to discuss URTI or gastric problem, but not the depression, because of the inherent stigma. This celebrity which I started in the initial slide has done this movement last year after being depressed for a month or so. She has gone with one NGO, Live, Love and Laugh, and she was launched to mainly through mental health awareness. The theme was on the depression of World Mental Health Day. This year theme is dignity in mental health. We are going to have on 10th of October. Recently we have passed some related topic, how to prevent suicide by reaching out and saving lives in World Suicide Prevention Day. So thank you for being here and listening and attending the things in a better mood. Partly it was scientific, partly it was applied, partly it was the general things to manage our level of well-being. Useful at all the course. Welcoming questions, comments, additions, deletions, and more so contribution.